Good evening, and welcome to another edition of Mental Health Mondays, brought to you by Saving Grace Community Church and Grace House Cincinnati, a ministry of Saving Grace, a nonprofit ministry of Saving Grace Community Church. We're excited tonight, once again, joining us, our resident expert, Dr. Quentin Moss, founder, president, and CEO of Modern Psychiatry. Good evening, my brother.
Good evening. Glad to be here. Thanks for having me back on.
It's always good to have you, and we always appreciate your insight and knowledge. Tonight, we have a another engaging and fascinating subject, a issue that affects many people. Tonight, we just want to say if you're watching tonight and perhaps you've been diagnosed with bipolar disorder, we're going to look tonight as our topic is what's behind bipolar disorder. And probably, or maybe you may not have been diagnosed with having bipolar or suffering from bipolar disorder, but maybe someone in your family has, or you know someone perhaps at your job, or perhaps even in your church. And so if you have been diagnosed with bipolar disorder, or you know someone, you ought not feel that you're alone, or you don't have a lot of company. Some very famous people, those who are into the pop world, Mariah Carey, even Jimi Hendrix, for those who are older and early rockers, Demi Lovato, and and so there are many people who have been affected, and so Frank Sinatra. So tonight, Dr. Moss, we know that this disorder affects men and women equally, and about almost 3% of the population here in the U.S. Have been diagnosed having bipolar disorder, and of those, 83% are classified as being severe. So help us to understand and to know what's behind bipolar disorder.
You know, I'm glad we're talking about this tonight. We use the term bipolar disorder kind of freely sometimes as we talk about how people act or personality styles. But truly, bipolar disorder is a brain illness. It's an illness where we can identify certain receptors in the brain which are not working properly, certain chemicals that the brain uses to function, which truly are out of balance. And then it also affects, neuronal pathways, circuits in the brain, and how they recruit various regions of the brain to be able to do simple things as carry on conversations, complete tasks, problem solve, but also modulating emotions, being able to conceptualize things, and managing our boundaries in our relationships. So if you can think of many aspects of what we do, when we think about brain function, bipolar disorder may have some effect on that. There are chemicals in the brain like dopamine, serotonin. We've heard of some of those things, but those are some of the neurotransmitters which are affected by this illness. And thanks to God, we have ways that we can diagnose this condition and ways that we can treat this this underlying, truly a health disorder.
Okay. So if I've been diagnosed as having bipolar disorder, what does that look like in a person whose ability to function? What should I expect if I receive that diagnosis? And when I know people that may have it, what should be glaringly obvious?
Well, let me further classify this. Bipolar disorder is in the category of a mood disorder.
Okay.
Much like major depressive disorder, depression is a mood disorder.
Okay.
And for most people who suffer from this illness, when we talk about them not doing well or not functioning well or being heavily impacted by the illness, 85% of the time they're in a depressed state.
Mm,
A depressed state that looks much like when someone has clinical depression,
mhm,
difficulty with enjoying things, difficulty concentrating, difficulty with motivation, sad or irritable mood, difficulty with sleep or appetite. Depression and bipolar depression look very similar,
mm,
though we believe that bipolar depression is a lot more difficult to treat.
mhm,
So I think that many people can recognize that. But the other part of this that gives the definition of, let's say, a bipolar disorder type 1 is
mhm,
someone who experiences mania.
mhm,
So, aside from what they may experience from the depressive symptoms, or even at the same time while they are experiencing depressive symptoms, they may have difficulty with racing thoughts, too many thoughts going through their head, speaking too fast, right? Lots of ideas,
mhm,
very impulsive,
mhm,
doing things that are really out of their typical self. They
mhm,
may find that they don't need sleep. There's an imbalance of energy, right? So
mhm,
very hyperactive, becoming grandiose, have an inflated sense of self.
mm,
People may tend to participate in behaviors that they don't typically participate in, whether it's infidelity or promiscuity or drinking alcohol or using drugs. Some of those things may come out of that.
mm,
Or people may become super nice. They may
mm.
decide to give out hundreds of dollars at a time.
I have
They may give
what that was happening, but
but they become hyper altruistic, too giving of themselves without boundaries. And they may find themselves spending an excessive amount of money. So when we ask clients, do you spend a lot of money in the midst of these episodes? Well, no one has tons of money, but the money that was due for rent or the money is due for your mortgage or for your light bill, you went and bought, 10 pairs of shoes that you really didn't need, or you went and bought 2 or 3 phones on a
wow,
credit card that you really didn't need. I mean, those are some of the behaviors that we see with someone who may be experiencing a manic episode. And some of those episodes may occur at the same time that someone is depressed,
wow,
which we'll call that a mixed episode. So that's bipolar disorder type 1. And then bipolar disorder type 2, people have a substantial depressive episode, and they may have a hypomanic or a less intense manic episode. But that depression, I tell you, with bipolar disorder, particularly bipolar disorder type 2, very difficult to treat.
wow, wow. You mentioned as you described some of the behavior, what that looks like. I thought about several things in which the diagnosis or behavior could be confused with something else. Very often times, it's said by health professionals, mental health professionals, that um, schizophrenia
Yeah.
is often confused with bipolar disorder. Can you share with us the difference between bipolar disorder and schizophrenia?
So you can think of, as I mentioned, bipolar disorder being primarily a mood disorder, right? Disruption in my mood, sometimes with my behavior. Schizophrenia is more so a psychotic or thought disorder. When
Okay.
people suffer from schizophrenia, again, another brain illness, people have distorted thought patterns, very distorted or sometimes bizarre behaviors. They
Hmm.
may experience hallucinations, delusions, paranoia, or their symptoms may be so impairing that it's really difficult for them to function, to initiate conversation, to really manage themselves. So that's what we can see in some of the most severe forms of schizophrenia. For some people who have bipolar illness, they can cycle through periods of psychosis in the midst of their mood episodes.
Hmm.
So they possibly can hear voices or see things or have distorted thoughts or paranoia or delusions within their mood episodes. So the way that I would separate that is if I have mood symptoms plus I have psychotic symptoms going on at the same time, that's likely going to be a form of bipolar disorder. If I have predominantly psychotic symptoms without a lot of the mood symptoms, that's primarily schizophrenia. Why this is important for people of color is that historically, whether you're seeing a Caucasian or a Black psychiatrist, people of color, when they present with mood and psychotic symptoms, we tend to focus on the psychotic symptoms and we
Mm.
miss the mood symptoms. And we disproportionately may diagnose people of color with schizophrenia when in fact they may have bipolar disorder.
Why is that?
There's a great deal of bias. We've seen even with those of us who are trying to be the best stewards of how we practice medicine, there's still bias in how we treat individuals, and that bias leads us down diagnostic paths which sometimes can be inaccurate. And then there have been stereotypes and behaviors of people with mental illness. And
Mhm.
those stereotypes seem to cling tighter to people of color. So we tend to think about people having more severe forms of illness than they may actually have. And since we tend to oftentimes, unfortunately, diagnose people inappropriately with schizophrenia.
Wow.
But to be able to tease this out, it takes one having the knowledge, which all physicians will have the knowledge, but
Mhm.
also takes time in talking to the client, understanding cultural nuances, those things which can also heavily impact how we diagnose.
Is there a type of, because I understand that in diagnoses there are various theories about social behavior, and many of them have been developed um, by folks who may not be in tune with the African American community. Presently, do you know of any therapies or treatment options that are specifically designed and targeted for persons of color?
Oh, so now you've expanded outside my wheelhouse, Pastor. So no, no, I do not. But
Mhm.
what I will say is that the American Psychiatric Association is making great strides in trying to develop cultural competencies,
Okay.
not only in how we treat, but how we diagnose.
Mhm.
And probably it's been maybe 20 years ago,
Mhm.
there has been a cultural formulation that was been
Mhm.
associated with how we diagnose folks. And fortunately, I was able to meet some of the people who've been involved with that. So we're trying to get more minority representation in these work groups and committees that talk about how we diagnose people,
Mhm.
but also more minority representation and just more knowledge in
Mhm.
how we can best create training programs for physicians and for residents and medical students. So
Wow.
that's an area where we are improving.
Wow. Well, that's good news. That's good news because I would think as a professional, you could probably say safely, and I could say this without anticipating you disagreeing with me, that every case and situation is different.
Every case and situation is different. And what we have been challenged with in psychiatry, unlike primary care, internal medicine, cardiology, is that they often have a blood test or they may have a machine that can may take a measurement and say whether you have a condition or not.
Hmm.
And with what we do in psychiatry, a lot of it's the history that we get, the interview that we perform, and
Hmm.
trying to pull that information together. I will say that a lot of research, some of which came out of the University of Cincinnati,
Hmm.
has shown that people who have bipolar disorder may have very distinct patterns in how their brain functions.
Oh,
So
wow.
if we were to put the brain under a functional MRI and ask it to perform tests, what
Hmm.
lights up on that scan may be different for someone who has bipolar disorder as
Hmm.
opposed to someone who does not have the illness. So I see in the future that's probably a direction that we're headed. We're just not there yet.
Okay. So we're getting to the point where we may be able to narrow that in
Oh,
uh,
yes.
scientifically and medically. Sure.
Mhm.
Well, one of the things I know just by living is that I seem to run into people and their behavior seems to be abnormal. And we do say sometimes jokingly, "You're bipolar," or
Right.
"You're
Right.
bipolar." But I see people whose behavior seems to be abnormal of a wide uh, age range. And so the question I have is, at how early of an age is bipolar disorder? Um, do people begin to show signs and symptoms and the diagnosis for bipolar disorder? Is it something that occurs later on in life, early
Mm.
in life, um, or where on our personal lifespan might this crop up? what we would treat as diagnosis?
So as we, tend to find people who may have bipolar 1 form of the illness, which is primarily a manic episode that I described, we see those individuals start to have challenges very late teens and early 20s, right? So that's where we may see some of those symptoms. However, the challenge with bipolar illness is that when people go to seek care,
Mm-hmm.
they often don't go to seek care when they're manic or hypomanic.
Okay.
They don't go to seek care while the party is going on,
Yeah.
right?
Mm-hmm.
They may get brought to care by family members or friends, or they may end up in the hospital, but it's not often that they come seeking care for that.
Mm-hmm.
People come to seek care because they're depressed.
Mm-hmm.
So when they're in that phase of the illness, that's when they may present to their primary care doctor. And many times when they're presenting depressed, they don't recall the manic episodes. They don't recall the hypomania. Those things aren't front of mind. Their depressive symptoms are front of mind. So we may have a 10 or 15-year delay
Mm-hmm.
between the time that someone starts to have symptoms before that we can actually get the right diagnosis,
Wow.
which, creates, significant difficulties with this illness. So one of the challenges with bipolar disorder is that the more episodes of depression or hypomania that you have untreated, the more episodes that you're going to have.
Wow.
So you're creating insults to the brain, toxicity to the brain over time that actually has the brain at a greater risk for developing more episodes, as opposed to someone that we're able to catch them early and we're able to provide appropriate medications and intervention to help them protect their brain as they get older.
So, like many illnesses, early detection and treatment is crucial.
It is crucial. So if you could think about the person who suffers from severe depressive illness
Mm-hmm.
and how that impairs their ability to get higher education or to stay in school or to be able to maintain a family or find a mate or to maintain that employment. People who have intermittent manic episodes untreated, and they may build this life that's great, and then within a couple of weeks, create such disruption that's kind of hard for someone to rebound from. So the sooner that we catch it, for sure, the better, just for the sake of the brain, but also these other negative outcomes that may come out of having the illness.
Wow. 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 Is this, is this like any other condition? Is something one of our persons, our viewers ask, is this hereditary? Is this something that someone should be concerned about and then pass down to their children from one generation to another?
Yeah, so if I have major depressive disorder or if I have bipolar disorder, there's greater risk that my children may have some form of mood disorder and more likely bipolar disorder. So there is a genetic component to this for sure with heritability. And there are probably more than 30 genes that are associated with this condition.
Wow.
So yeah, this is when we think about, how we define a chronic medical condition, this is a medical illness that we can diagnose that has a genetic influence, that has chronicity or is prolonged over time. And there are, biological treatments for it. So this is truly a chronic medical illness, which causes a great deal of disability for many people worldwide.
So I guess the question is, how dangerous, and you've kind of answered the question, but how dangerous is it for a person to have been diagnosed with having bipolar disorder and is aware that they have that condition and to abandon treatment and not to cooperate and comply with the treatment plan?
Yeah. So I think it's detrimental. I don't like to use the word dangerous because then people start to label people with mental illness as being dangerous or violent people. And when we make comparisons to people who don't have illness, it doesn't pan out right.
Right.
People are just people. But being detrimental, not receiving treatment, it's huge. We are in the position of trying to save and preserve the brain so that it can maintain its function. For people who don't receive treatment, who continue to cycle and cycle and cycle, there creates this risk of a downward drift.
Mm.
So I move downward with my ability to maintain relationships. I move downward with my ability to really provide for myself with gainful employment. And I move downward with, my cognitive ability. What we haven't talked about is that people who suffer from bipolar disorder, have a great deal of cognitive disorder, meaning thinking speed, memory, cognitive flexibility. A lot of those things have been impacted by having this illness.
Wow.
I've spoken a lot about, what this illness can do, but I also want to share that there is a lot that we can do in medicine and treatment to be able to help people that they can, restore their brain and they can be as functional and as giving, as loving, and great contributors to society, just like everybody else.
So that's critical because, this is something that will a person have to live with this diagnosis? Will they ever, is it possible for a person ever to be healed from this? And so to your question, what are the treatment plans and options if this is something I'm going to have to live with?
There are probably 4 or 5 areas that I would concentrate on. So one, what's my major wheelhouse is, prescribing medications, but we have a number of medications which have been shown to be very effective. I could talk about some of the older medications like lithium. Lithium gets a very bad rap. It gets a very bad rap, but it's one of the most effective medications that we have for bipolar disorder. Has restored a lot of people in their lives. Has helped save a lot of lives. Like it helps people even with depression. So lithium, though an older medication, has been shown to be very effective, and it still remains really the gold standard of how we can treat people. But there are other mood stabilizers that we can prescribe. There are antipsychotics, not because people are psychotic per se, but some of our newer antipsychotics really target a number of receptors in the brain. And these receptors are also associated with bipolar illness. And they've been shown to be effective in even treating, bipolar depression. Imagine that, using an antipsychotic to treat depression, but it works. And the FDA has, reviewed these studies that shows that these medications are effective in helping people. We try not to use antidepressants too much because antidepressants run the risk of making someone manic. Though there are select few that we may have to use those medications. So that's medications. But then there are also talk therapies or counseling, which has been shown to help people maintain stability with the illness. There's also the structure of routine, social rhythm therapy, where we try to train people, like we all really should do, to do routine things, meaning try to go to bed at the same time, trying to wake up at the same time, trying to eat your meals at the same time, have a structured day of the things that you want to do, right? Exercise, right? Physical activity, connecting to other people. All of those things have been shown to be very effective and help people maintain the illness quite well. And when I talk about maintaining the illness quite well, I'm talking about doctors, lawyers, politicians, entertainers, who've been able to have a great deal of success in maintaining their lives and their families in the midst of this. The last thing that I would say, then I'll let you talk, man, because I could talk forever about this.
You rolling. I'm speaking for people that are watching and will watch. This is wonderful. Keep going.
But one of the things that I would give a lot of caution with is substance use. So when we introduce alcohol into the mix, we create a totally different entity with this disease state. When we, of course, use, abuse pain medication or nerve pills, when we use meth, it really transforms this illness into something that becomes even more difficult to treat. And then even the issue of marijuana, there is no evidence that states that even medical marijuana would be an appropriate treatment for people who have bipolar disorder.
Wow. So a shout out to all of those self medicators.
Yeah.
That while you see marijuana as a mild drug, it is a drug. That's critical. So in the faith community, and we always come back to the faith community because some behaviors can be confused with someone being demonic under an evil influence, which they may, but oftentimes it's mischaracterized in a faith community. How does mania, how does bipolar depression, what does that look like in a faith community? What behaviors accompany that in a faith community?
Well, when I tend to think about that, I don't think about bipolar depression as much as I think about someone who's manic.
Okay.
And when we have someone who's manic, their illness oftentimes takes core beliefs, core drives, personality traits, and it takes that and it distorts and it exaggerates them.
Okay.
So when someone comes in with a particular faith, upbringing in a spiritual formation, when they become manic, it can take that and distort it.
Mm-hmm.
So people can start to quote and say things that are well beyond what they would typically have in a spiritual experience. They can say that they've had visions. They can say that they've heard from God, or that God has commanded them to do this, or they may have special healing powers, or they may call themselves Jesus outright. All right. So that gets concerning. And this is where it's pretty challenging. And what I've taught people in the past is that try to find an understanding of what their foundation is with their faith or with their spirituality.
Mm-hmm.
And try to see if what people are exhibiting now is in contradiction to what their foundation is, or is in contradiction to whatever their holy or spiritual script or text is. If there is a blatant contradiction there, and we believe this person has illness, it's likely that this illness has taken their spiritual life, and unfortunately for that period of time has distorted it or exaggerated it.
That's a critical point, because I think that we see, some persons in the past, televangelists who have professed to be God. Jim Jones is some example many years ago. But even in this current political cycle, we find people making statements and really believing that perhaps people can become impregnated by aliens. And when we hear those things, you have to ask the question, is there something wrong with this person who is floating this idea, which does not seem to be connected to reality?
Mm-hmm.
And so I think that the general public, as we become more aware of mental illness, hopefully we'll be able to train our ears and train our eyes, and our level of discernment will be rise to a level based on the information we receive, that this is a spiritual, but this might be a mental piece as well. And so I think it's critical that we have these discussions, and I think it's critical that we become aware to help us gauge and make the right decisions when it comes to who we'll follow, who we'll support politically, and perhaps whose church we might join as well.
That's true too. It's interesting, Pastor. I was on a Facebook chat with some other preachers, and they were asking, whether people in the pulpit should be able to lead a church or preach if they have bipolar illness. And there were varying opinions. And my opinion is people who suffer from, various forms of mental illness, are people who still make, profound contributions to our lives.
Yeah.
And I believe that people, in the pulpit indeed can suffer from illness. Though I would encourage that, for anyone who suffers from this form of illness, having someone who's trustworthy, who can support them, but who also can give them feedback, in regards to how they're doing in managing themselves. I think that's crucial.
That's critical, because, when you look at clergy, when you look at, ministry, that there are a high number of suicides, and admittedly, there are a lot of pastors who suffer from um, depression.
Hmm.
So finally, tonight, on that same line of questioning, um, question has been presented: how does a believer um, uh, shepherd someone to help? How do we, in the faith community, or if not in the faith community, perhaps someone we have a close friend, how do we steer them um, to get help, or how can we help them?
I think that the biggest lead in is to lead in with the motive of love and caring,
Hmm.
and trying our best not to be judgmental.
Hmm.
I think that is the big thing, letting them know how much we care about them, how much we're there for them, and we may have some concern that they're not being their best selves.
Yes,
You
yes.
know,
Hmm.
and if I'm recognizing these things, then this is where I would suggest that you may want to start seeking some help or having a conversation. And this, seeking mental health care, as a psychiatrist, I tend to say that I think it's very easy, but as a patient, it's difficult and it can be scary,
Hmm.
right? Because I don't know what Dr. Moss has behind that door when people talk about people who have mental illness.
Right.
So, being able to be a support for them, when they do go to seek care. If they want you to accompany them, great. But maybe having a follow-up phone call after that visit, these find ways that you can support them. And then the other thing that we can do as a community at large is just be mindful of our conversation in regards to mental illness, stereotypes that we talk about, stigma that we inadvertently let fly from our lips, because that really prejudges people in regards to what mental illness is and whether they should get treatment for their mental illness. So again, and the church, I think, could do an increasingly better job of talking more openly about mental illness, much like what you're doing. To
Because
talk from the pulpit, to have someone come give a
mhm,
5 minute introduction about different forms of illness, so that when we talk about mental illness, it's
mhm,
almost like we're talking about high blood pressure or diabetes,
right,
right? It's not a weighted conversation. It's
right.
something that we all should be open and being able to have some discussions around.
Well, once again, Dr. Moss, has been phenomenal tonight. I can't believe we've gone past 30 minutes. It's been great.
Oh,
And yeah, yeah, right. And so to our guests, we want to thank you for tuning in tonight. Uh, we hope that the information that has been talked about and discussed has truly been helpful to you uh, tonight, and that if you have recently received a diagnosis of, of bipolar disorder, or you know someone, I think it's critical that you know that life is not over for you,
that's right.
and you still can live a very full and productive life. And so we wish everyone a very, very happy Thanksgiving. Thanks again, Dr. Moss.
Glad to be here.
And so to our viewers, we want to say to you, until next time, feel better, live better, become better. Have a blessed evening.